what you see here, that little QR code, if you scan it with your cell phone, will take you to like a stroke knowledge test, basically. The idea here is if you have a minute while we're kind of getting ourselves sorted out, you could go ahead and log into that. It'll ask you for your email, and then you'll just run through a little quick quiz. If it's too long or if there are things that you don't know, just skip it. You know, it's nothing formal and it's nothing that anybody has to do. But what we're trying to do is get an idea before the lecture about, you know, what you know about stroke, and then after, at the end of the lecture, we'll put that QR code up again, and you'll retake it and see kind of what you learned and where we need to focus more on, you know, education in the future. So thank you guys so much for your time.
Maybe it'll show up at some point. I can just go ahead.
I certainly hope so. I promise.
I thought we could just test.
We'll figure it out.
Yeah,
that works.
Okay.
Hi guys.
Nice to meet you.
So this is the contingent in the room. This is pretty special. Everyone at home's missing the cake. That's disappointing. I assume there's cake.
I was looking around for it.
Yeah, right?
Okay. Maybe I could just get started, and then we'll just switch over when I'm done.
Can you do it?
Yeah.
Can everyone hear a sound check?
Yeah.
I think everyone can.
Yeah, can you, another thumbs up, please, from our online friends who can tell us whether you can hear me or not.
Cake for the first person
Yep.
online? Yep. Nice.
Seems like it. All right. Okay, so hi, thanks for joining everyone. My name is Kishan Patel. I'm one of the stroke neurologists with Providence. So I have Dr. John Dussell, who's a vascular surgeon. And together we will be talking about stroke prevention. I will go over, my part of the talk is going over the stroke risk factors, some stroke stories, figuring out what different aspects of stroke care, from urgent stroke treatment to prevention aspect. And then we have the pleasure of hearing from Dr. Dussell about how do we manage carotid artery-related stroke risk factors and what options we have. So I'd like to just start with the question, you know, why should we talk about it? There are oftentimes we think about stroke, you know, it just strikes all of these words in our head. You know, it's, you know, all of a sudden, you know, it's the disability part of it. It's scary, it's expensive, life-threatening, the morbidity of its stroke. So it's in a way not talked about in a way we can beat this thing back. What can we do to make sure that we can control some aspect of this disease, either just prevent it all of a sudden to have, you know, what can we do to prevent our first stroke, or once we've had it, what all do we need to do to make sure that we have all the knowledge and we're doing best we can to prevent another one. So that's the objective, you know, trying to start from the identification of the stroke symptoms, thinking about emergency treatments, understand our risk factors, think about and work towards looking for the cause and coming up with the best strategy. So we use the analogy of a house on fire. Let's say all of a sudden you think a house is on fire, our first instinct is like, hey, let's just detect the smoke, take out the fire as fast as we can. Then we worry about, hey, what could have led to the fire? Then we think about, hey, wait, let's just make sure this doesn't happen. So that's the analogy we use. So before we get into the disease aspect and the stroke, I want to talk about just the brain health in general. This is because I'm going to be using a lot of brain scan pictures throughout this talk. This is how a healthy brain looks like. You know, this is a view of the brain from the top, the front, back, right, and left. This is a sequence called T2 flare, and this is a sequence that gives us a long time overview of someone's brain. Anytime in the past, anytime we've had a stroke, anyone who's had a stroke-like change before, any scars, it shows up forever. So this is a healthy-looking brain, no scars, no old strokes in this part of the brain. Right side is on your left, and left side is on the right, since the medical images are flipped. This is the second sequence that we use to identify fresh strokes. And again, this is something I'm going to be using down the line. This talk, right and left are flipped. If anytime someone has fresh strokes, it will show up with bright white spots, and we can recognize and compare it with the other sequence between old and new strokes. We generally, the blood vessel situation in the head and neck is like a map or a city map. There are some freeways, there's some sort of avenues and big streets, and then there's some small streets like that goes in the cul-de-sac and neighborhoods. So generally, there are 4 vessels that connect your heart to the brain. The 2 in the front, we all know the carotid arteries. 2 in the back are vertebral arteries, and they all kind of branch like a tree. As high as we go up, it branches into smaller and smaller one. And then different vessels have different patterns of blood flow, and we know like certain arteries supply color-coded arteries here, different areas of the brain. So based on that, we can know someone who's having a stroke pertaining to certain area, we can recognize, and it becomes a pattern. So this is a radiology view of an MRI of the blood vessel. So this is the head part, where again, think about like the big vessels, like a big trunk branching into smaller and smaller one, and higher it goes, it's like a small twig on the top. And these are normal, healthy-looking vessels. And like an MRI, this is a picture as if someone's looking in the mirror, except right and left is flipped. The 2 arteries in the front are the carotid arteries, and the 1 in the back are the vertebral arteries. And this is the heart down here. So this is what we like to see. Now, stroke by the numbers, we have annually about 800,000 strokes, and we divide them between an ischemic stroke, which is a blockage-related stroke, and the rest, the minority, tends to be a bleeding part or bleeding-related stroke. It's about 10%, 15%. And the concerning part is when someone has had a stroke, what are the odds of having another stroke? And that number is still quite high, at about close to 200,000, but we're doing better compared to 50, 70 years ago. It used to be 10%. Now with better risk factor control and recognition and blood thinners, we have brought it down to now 5%. That number is from even 10, 20 years ago. The focus that I have on this talk is this 80% number, but that's the number that we attribute, like all the 80% of all strokes are attributed to a risk factor, which we will call preventable or modifiable risk factor, be it lifestyle, smoking, blood pressure, and we'll get into that. So that is the focus, and that's sort of a glass half full kind of way of looking at this, so that it's not this entity which is completely uncontrolled, or it's just inevitable. This 80% number is something we want to target. So what is an ischemic stroke? Think about that blood vessel again. Anytime there's the tree analogy, anything all of a sudden, any part of your brain suddenly losing function because of any plumbing issue. And that might be a blood clot, or it might be from a moving clot or a cholesterol plaque, anything that blocks the freeway, so to speak, and then causing some part of the brain to lose function. And this is the sequence that shows fresh stroke. So these white areas are fresh strokes. And in this particular case, these are the top view of blood vessels, and all of a sudden you see there's the cutoff here, or an interruption of flow comparing to the other side, and as a result you see area. So this is what we call an ischemic stroke. We looked at normal vessels a while ago, and these are all normal vessels. This is an illustration. Again, looking at the freeways, there may be some sort of interrupted, like a 3-lane freeway becoming a 2-lane freeway. There are these small vessels that have some disturbance or blockages. These are cholesterol deposition here and there. And this is a view of a blood vessel. You can see some arrows pointing where it should be nice and smooth and even, and all of a sudden there's some narrowing or a blockage here. This is the back part of the vessel we call vertebral arteries, and this is not supposed to look like this. It should be nice and open. So this is what the disease looks like in terms of cholesterol blockages, which is a risk factor or something that could lead to a stroke. We look at stroke function. So first, I want to look at, hey, what are the stroke symptoms? It's not something unfortunate like in the cardiac world where we have chest pain, shortness of breath, easier to identify than this stuff. Because you see your brain, it's a complex organ. All these different regions have different functions. So sometimes it's straightforward. We call it typical stroke symptoms. Your arm starts drooping, your face is droopy, your speech stops working. And sometimes it's like a little bit subtle. It could just be dizziness, it could just be headache, it could just be balance issues. And it all depends on what part of your brain's affected. Of course, you hear a lot about BFAST, and this is something it's extremely important, all of a sudden loss of balance, loss of your vision, face being droopy, arm being weak, speech loss in terms of articulation or language. If any of these symptoms happen all of a sudden, we want to call 911 right away and get to an emergency room as soon as we can. And again, the reason all of these symptoms you have such a long list of things to look out for, it really depends on which pipe or which street gets blocked and where's the plumbing issue, and that can cause all these different patterns of stroke. But BFAST is something that encompasses, takes care of majority of them, the typical stuff. Once we recognize stroke symptoms, get to the emergency room, we want to emphasize on time. We have a couple of emergent or acute stroke treatment options available. One is a clot busting medication. It's an alteplase or tenecteplase, which is the idea is there may be a certain blockage somewhere. Let's try and use it by clot busting medications. And the time window that's approved is 3 hours by the FDA. But based on some scientific studies, so we extended up to 4.5 hours. And then second treatment that's much around for the last 10 years is a clot removal, manual clot removal device treatment called thrombectomy. So I want to give you an example of a case we had 2 years ago. So a 52-year-old gentleman, is a Portland man, who was drinking his morning coffee, and suddenly he lost all his speech. He dropped his coffee mug and lost complete function on the right side. He lost all his vision on the right side. His twin brother was right there, and he had family history of strokes, and they recognized stroke symptoms and called 911 immediately. Somehow, because of how stressed our healthcare system is here, the ambulance wasn't readily available, so they just decided to put him in the fire truck and strap him in, and then just brought him to the emergency room. And when we immediately did some scans, we found out so it's top view of the blood vessel. This is the left side of the brain, and this is the right side of the brain. And you see, so all of a sudden there's a blockage here. That this whole like this branch just cuts off, and it should be going into smaller and smaller, taper down like this the right side. This is a 3D model of it, and it should be like this. And all of a sudden here, this is just the same blockage, just 3D view. It's just missing. So we can now correlate the left side of the brain controls the right half of function, and left side of the brain also tends to be dominant in majority of about 90% of us, even if you're left-handed. And all of a sudden you lose function there, you lose your articulation, you lose your verbal language skills, and then the right half of vision was also lost in this gentleman. He was brought in pretty quickly. He just got off by 9:40 in the morning. Because fire truck just made this decision to bring him in without even waiting for the ambulance. He was in our emergency room within 20 minutes. And coincidentally, one of my partners was already in the emergency room for another case. They looked at him, he was just not even put in a stretcher. And they identified that he had all of these signs. The right side was paralyzed, that right side had no vision, couldn't talk. We use a scoring system called NIH stroke scale. It was as 17. So immediately, since they ruled out a bleeding kind of stroke, they administered clot buster medication at about 10:30 within the first hour. We call it the golden hour. And since there was a large blood vessel that we looked at earlier, we activated our cath lab, which is a specialist neuroradiologists or neurosurgeons who help us out. So this is the view of his brain from the front. And this is looking at his skull. These are eyeballs. So this is the front view. We looked at it on this top view. And this is the same vessel. This is the left side, which is still blocked. And they go in manually from the groin using a catheter. And you can even see the catheter in the head. And they're injecting contrast beyond the blockage. So you try and crush the clot and then trap it with a stent and remove it. Or you use suction to remove it. And after that clot removal, which was 11 a.m., and you can see all of this part that was lost came back here. And that's why we use the term time is brain. The whole deal is very, very time sensitive. Longer it goes without blood, brain getting blood and oxygen, it starts to die out. And that's why, going back to the house on fire analogy, you want to try and limit the fire as fast as you can before it spreads. He did have small strokes on the MRI, but they were so small and scattered compared to the whole left side that would have been lost, that he had such rapid improvement that he walked out of the hospital on day 2. And he had known history of atrial fibrillation, which is a risk factor. So he started on a blood thinner so that he doesn't have another stroke. We did reduce the risk of another stroke. This whole story was so unique and from the fire department standpoint that we did a news story 2 years ago, and he's doing really well. But the essence is, everything is time sensitive. Had he any one of these things had it not happened, we wouldn't have such great outcome. And the best thing was identification of stroke symptoms. So early treatment really matters. So now to the next part, understanding your stroke risk factors. I want to give another story of one of our patients. She's a 58-year-old woman. She came to our emergency room with 5 days of headache, left-sided weakness, and she noticed that she couldn't move her tongue while playing a game on the iPad as well as the other side, and numbness on the face and the arm, and her balance wasn't as great as before. All of these were one-sided symptoms. She didn't really think much of that. But so she took her time coming to the emergency room. And another important thing here, even 1 week before all of this, she had about 10-minute episode of numbness on the left side. When we did took some pictures of the brain, we found out that she actually had a stroke on the right side of the brain. And this is the side. This is a illustration of what area was affected. And this is what we call a sensory cortex, which controls your sensation and sometimes just coordination as well, together with the movement. And based on how we saw changes on both these sequences we looked at earlier, one is a fresh stroke, one is like not as fresh, but it's been going on for a few days, that it already started forming a scar that matches with the timeline, 5-day-old stroke on the right side of the brain. So then we want to look at her pipes or blood vessels. And then when we did this study, this is the CT angiogram, CT scan with contrast, we found out she had really tight blockages in a couple of areas of the brain. This is the right side of the brain. This is the other gentleman case we looked at was the other side. It matches with the stroke. And it should be nice and even. All these branches of the tree shouldn't be just tapering here so tightly in a couple of locations. But in her case, this was the reason for her stroke. So with this background, I'm going to get back to her case data. I just want to talk about what are what we call modifiable risk factors. Some of them are lifestyle, and I'm going to talk about all of them in some detail. But high blood pressure, high cholesterol, diabetes, tobacco use, extremely concerning, and smoking and vaping as well, substance use, lifestyle factors, especially in form of inactivity or lack of exercise, and then sleep apnea. What some of the non-modifiable risk factors, if you have certain cardiac condition that one may not even be aware of, autoimmune, genetic clotting issues, trauma or accidents or mechanical injuries. I'm going to be covering some of them, but from all of the above, I'm going to spend some time talking about a few of these things that we can share some more insight. First, the most important, I would say, is the uncontrolled blood pressure. This is directly related to high risk of clot formation, the blockage cholesterol blockage formation in the blood vessels, as well as risk of bleeding. The American Heart Association, Stroke Association goal is to have blood pressure less than 130 over 80. And I would put this as number one in comparison, just similar to tobacco use. And the reason for blood pressure risk factor in stroke is how it affects certain areas more than the other. So let's say, we use the traffic analogy and the freeways. There are some areas like in your city or your map, some regions where you have an exit coming or they're merged. There is a lot more turbulence in terms of traffic. So certain areas get hit a lot more than the other. So the picture on the right is like an illustration of your blood vessels. Whenever you have some certain areas in the carotid in the neck, in this woman's case, carotid artery, when it enters the head, it's uncontrolled blood pressure hits the large vessel and that damages the inner lining, and then because of inflammation, cholesterol deposition, and then you have either interruption of flow or just clot breaking loose and causing problems. So this is the large vessel, and certain areas are more involved compared to some other ones, but smaller areas are also concerned. So this is an MRI, it's a 7 Tesla high resolution scan of the brain. There is a situation here where there are certain vessels right here that get affected a lot more than the others. And the reason is that these are these hair-like thin capillaries that come off directly from the big blood vessels. And years and years of uncontrolled blood pressure, years and years of fluctuating blood pressure takes a toll on these vessels, and they can either just it's an elastic vessel, so keep stretching it in various different directions, and it will lose its elasticity and close, or just rupture. And the analogy again I would use is, think about how if there was a freeway which would give rise to a neighborhood in a cul-de-sac, how much stress there would be in these vessels. And unfortunately, we have this big trunk giving out hair-like blood vessels, and unfortunately they supply a lot of critical areas which cause significant symptoms. So I would pay a lot of attention to blood pressure, and this is easily controlled or modifiable risk factor. Not only just the stroke, but we also see evidence of cognitive impairment, dementia, and we call it vascular dementia, if we have years and years of uncontrolled blood pressure. And these are similar areas that I just showed you on how these are supplied by thin blood vessels, which are very sensitive. And this is an example of how it would look like if it was a milder case, moderate, severe. If you have years of these white spots developing, it's oftentimes just related to this blood pressure story. And you collect enough of these white spots, eventually we start losing our brain function or cognitive function. And so I would put even this whole deal as preventative outcome. And so there are certain areas that are very, very critical, like this is an internal capsule region. The movement fibers pass right through this. So it's a choke point in the brain that even a small 1 centimeter stroke here, because of this process, can take out one side movement function. And certain areas like the hippocampus and thalamus are even involved in our cognitive function. So unfortunately, they are supplied by these thin blood vessels as well. So that's from stroke and brain health standpoint, this unfortunately is extremely important to not have uncontrolled blood pressure. Next up, in terms of cholesterol deposition, we talked about some of them already. You get your cholesterol panel checked with your doctor. You can hear the talk about good cholesterol, bad cholesterol. Once someone has had a stroke, we want to target this LDL, which is the sort of bad cholesterol, to be less than 70. Normally, it's less than 100 before someone has had a stroke. So we want to be a little bit more aggressive after that. We use anti-cholesterol medication, oftentimes statins, which this is a very common question we get from our patients. Do I have to take this? And they may have heard things in social media or just in their social circles. And the way we explain it, so once you've had a stroke and once it's due to a cholesterol-related process, you kind of want to have maximum aggressive care to calm these areas down. And this is an example. I use the analogy of like an active volcano versus like a dormant volcano. Things are different. They all look the same from far. But you want to use these medications to stop this inflammatory effect as well as stop this stuff from growing. And so things are a little different when we interact with our patients in terms of what tools we have. And statins are very useful in stroke prevention in our world. There are some non-statin medication that if someone can't tolerate, we can use. For instance, Zita or Zitamib, that works a little bit differently. And nowadays we have injectables as well for very aggressive, hard to treat high cholesterol situation. And then lifestyle-wise, we have evidence, scientific studies showing decreased risk of stroke, heart disease, and blockage formation with a Mediterranean kind of diet. And the goal is to increase food which contain sort of the good cholesterol, high monounsaturated fatty acids. You think about, so olive oil-based cooking, just switching to that is shown to reduce risk by 13%. A little bit more plant-based foods, increased consumption of fish, white meat, and less ideal, I wouldn't say just don't, like it's not completely, just moderation is important for red meat, cheeses, dairy products, and junk and processed food, because we know these raise your LDL level. The next one I want to spend a few minutes talking about is the sleep apnea. I would say this is so prevalent for our stroke patients, and it's a risk factor. And let's say some of the common signs, symptoms for that is snoring, having pauses or apneic spell is what we call it, when your loved one can be observed having interruption in their breathing pattern, and then for a few seconds they just stop breathing and then just wake up with a gasp. They wake up in the morning not feeling fresh, daytime sleepiness, headache, fatigue. And just to give an example of how common this is, we at our centers here in Providence, we run a NIH sleep trial where we are looking at, or NIH is looking at evaluating patients who are already admitted and seeing if someone has sleep apnea or not, since we know how common this is. We've screened about 80, close to 90 patients, and only 2 of patients did not have sleep apnea. And oftentimes, sometimes patients wouldn't even have all of those symptoms. So it is something that's associated not only with stroke, but heart disease, fatigue, and even cognitive decline. It's the lack of oxygenation for several times an hour. More than 30, where your oxygen level would drop below 70, 80, sometimes even 60%. And your body and just brain and heart just starves out. So it's extremely important to get screened and treated, because this is, again, one of those modifiable risk factors for stroke prevention. Inactivity is unfortunately rising in advent of work from home and just the lack of physical activities. This is something we see very commonly even in young patients. We know there is an increased risk of stroke and heart disease for inactivity, and this was studied on a clinical trial, and where people were given tasks like minimum 20 minutes twice a week or 10 minutes 4 times a week, and it was successful in reducing risk of stroke. So this is something that American Heart Association recommends. This for the duration of time where we would like patients to at least, or generally everyone, to avoid getting into the situation. If you work from home or you just have a sedentary lifestyle, just break it up, take a break, and as soon as short as 3 minutes of a break can help. Again, this is something that's easily preventable. We use blood thinner medications to prevent stroke. So, if you've had a history of stroke or a TIA or blockage kind of stroke, we use different kind of options. Aspirin, or something called Plavix or clopidogrel for someone who's had a stroke or a large blood vessel stroke. TIA, we use a combination of them up front, and then one of these on a long-term basis. Like the first case I discussed, if there are certain conditions like atrial fibrillation, where we use a different kind of agent. So because of these reasons, for treatment, different options that we have at our disposal, it is important to find out the right cause. And that's something I'll focus on next segment. But going back to the woman's case I discussed, she came to us, we diagnosed her with the case, with the right-sided middle cerebral artery stroke from the narrowing. We did certain tests, we identified what her risk factors were. She had new diagnosis of high blood pressure, sleep apnea, and diabetes. She also had this LDL level, which should be less than 100 normally, was 200. And there's another special aggressive kind of cholesterol particle called lipoprotein A that is an independent risk factor for stroke. All of this made sense based on what we found on the brain blood vessel in terms of narrowing. So we established that was the cause, and we target all of these risk factors differently. And together we call this maximum medical management. Even though at the time that narrow segment looked really scary in terms of, is this strategy going to work or not? Why don't we just put a stent there, or should we put a stent there? When they did studies in terms of having blockages inside your skull causing stroke, this approach was proven to be more effective compared to putting a stent in the head, which is the different strategies than elsewhere in other parts of the body. So against the 3D view of our blockages, But in case things worsen, as a contingency, we could still go ahead and do a stent where they can deploy a spring-like device here to open this up. But it's been 3 years, and I just met her 2 weeks ago, and I think she's doing great. And all of these risk factors are very, very well controlled. So again, the analogy I would use, thinking back of freeways and streets, if the brain does a really good job at kind of connecting, creating new channels, new roads, if this is blocked, people will eventually figure out different routes of going to wherever they want to go, and same applies. And over time, as time goes on, the risk of that plaque causing problems with aggressive risk factors becomes less and less and less, because that vasculature or the blood flow to that brain becomes resilient, and it kind of develops new channels of getting the blood flow. We call it collateral flow. So far so good for her, and I think with this current route, she will probably never need this plan B, but that is the benefit of aggressive medical treatment. And that's why these risk factors identification and aggressive treatment matters a lot. And so the next few minutes I want to spend is looking for the cause. And this is a complex slide here. This is an algorithm, and we follow this to find the cause, because the best strategy for an individual patient may depend on the cause. So very simply, you first want to diagnose or identify a stroke. Then you want to see, are there any blockages? How is that tree looking? How are all the streets and freeways looking? And if so, if there is any blockage, does that correlate with that stroke? If not, then look at the source of the blood flow, which is the heart. Look at the function of the heart. Look at the rhythm of the heart. Is there anything that can cause a normal issue, and like a clot formation in the heart, for example, like the first case, and then that can cause a stroke. And if not, then you have to look for rare cases. Fortunately, rare case causes are rare, and there are a lot series of tests looking at genetic problems, clotting problems, even looking at the heart in a lot more detail. Despite all of this, 1 in 3 instances, we never know when someone has had a stroke, but doesn't mean we don't have to do it. Oftentimes, the people have not looked hard enough, and that is why that number is so inflated. And I think as time goes on, as science evolves, that should get lower and lower. So to kind of highlight this issue, I want to talk about a third case, actually. We have a 71-year-old gentleman who met 2 years ago, who woke up in the normal state of health, and he was again having his breakfast, just looking out of his office, and suddenly just developed room spinning, lost his balance, and just fell back on the couch, and he could not walk at all. He started having headache, nausea, vomiting. His family had to help him walk to the car, and then eventually brought him in the emergency room. And he presented to one of the hospitals on the coast. When he went there and paramedics met him, he did not have any one-sided weakness, numbness, did not have any speech. He was talking just fine. The only symptom the room was spinning really hard, and he was throwing up, and he just couldn't stand up. He would just fall down immediately. So he was evaluated by our telestroke doctor, who was based in one of the bigger hospitals, and we would use telemedicine to evaluate patients. And he had arrived at that hospital at about 3-hour mark. And when we talked to him, and we know that he just couldn't stand up, and he was listening to his left side, and we did some CAT scan. He did not have any bleeding in the brain, did not have any evidence of blockage-related stroke. And which is the norm. Oftentimes when you're having a fresh stroke, it wouldn't show up on the CAT scan immediately. So a stroke possibility is not ruled out until you do an MRI later on. But we don't wait for that. The second study we did was a CAT scan with contrast, and then again looking at the branches, looking at the blood vessels, all your streets and freeways, and everything looked okay at that point. Because of the suspicion of a stroke in a certain area of the brain that we know that can cause just these symptoms without any one-sided issues, he was treated with a clot-busting medication. Later on, he came to our facility, and we did an MRI to do sort of a damage assessment. And this is the back part of the brain, or the cerebellum. Again, this is the MRI. We looked at the bottom part. This is the brain stem, which continues on the spinal cord, the nose. So it's a lower in the back part of the brain. And all this white stuff is the fresh stroke. And it had been a few hours already, so swelling was setting in. And then, so this is a blood vessel territory in the back part of the brain. And you can actually see a blood clot in another special sequence that caused a stroke. This is the side view, so you can get an orientation of what this area was, and lower in the back. This is involved in your balance, and between the two sides determines your center of gravity. So oftentimes you lose one side, it's the left side you kind of lean on because there's only your center of gravity shifts toward that side, so you just kind of fall down to the left side. So now, in his case, we've had looking at doing this exercise, what could have caused a stroke? So this is an illustration of what all different reasons one can have a stroke from, and it is complicated, but you can have, we looked at it before, you can have blockage in one of the blood vessels in the head. He did not have that. You can have cholesterol deposition in the neck. He did not have that. He did not have a mechanical injury or a tear in the vertebral artery which supplies that area. So that's why we have to kind of think, okay, this is not a flow or a vessel problem. So that's when we think about, okay, let's look at the heart. We did an ultrasound of the heart, everything looked fine. There was no visible clot or pumping issue or valve issue. We did a heart monitor to find out he has atrial fibrillation or a flutter of the top left chamber, and he did not have that. So when we met him, he got a special ultrasound with what called bubble study, and he found out that he has this issue called PFO, where a right top chamber of the heart connects with the left side, and 1 in 4 times it's like a flap, it's a one-way valve. So for some reason, if you have a leg clot or a lung clot, this clot just usually is a small one that doesn't really cause that much issue, can cross over and cause a stroke. So when we did some more studies, we found out that he actually had been immobile for a long time, and he had a clot formation in the leg that had traveled up to the brain using this sort of one-way flap. So it's a rare things, and a lot of things have to go wrong for you to have that, but it's the whole exercise is important so that we can address it appropriately. So once we found out he actually has an existing clot in the leg that could shower again and cause the clot migration from right to left side, he was switched to a stronger form of blood thinner to prevent this from disintegrating further. And then, although and this is an option, and he's still under consideration. He actually had this a couple of years ago. So where cardiology colleagues can go in and close this flap by putting this device called sort of a PFO closure procedure. Oftentimes, this whole deal is one of the common causes of stroke in young people. But if the risk is high, and we close it below 60, but sometimes by case basis, you can close this area to reduce the risk of this kind of stroke from happening again. So thinking about the cause, different types of stroke patterns on brain scans can also give us some clues. So for example, this is the whole big one-sided stroke territory. Had the first case example I showed you would have had this sort of a stroke had the clot not been taken out. Tells us this is most likely from some other source completely blocking the artery. Sometimes we can have a low blood flow related stroke where there's just instead of a 3-lane freeway, it becomes a 1-lane freeway, and multiple arteries are blockages, and not much blood is getting through, and someone may lose blood or maybe become severely anemic. You can have this sort of, we call it a watershed strokes. Sometimes it's a deep area strokes. These tend to be due to these small microscopic thin vessels that I showed you before, which are very, very sensitive to high blood pressure, and some of these risk factors. Or sometimes you can just have this shower, like shotgun pattern all over on the outer side of the brain, which is what most likely tends to be due to undiagnosed heart issues like atrial fibrillation or a moving clot or a clotting issue. So this whole exercise is important, looking at the cause, and it gives us some clues. My last segment is just looking at the stroke incidence and issues in our young folks. And unfortunately, we're seeing a rise. Just thinking about last 10 years comparing to the previous 10 years, decade on decade, we see about 3% rise in patients under 50 who have been presenting with stroke. And a lot of these factors are lifestyle related, where there are instances where people just don't know their risk factors, haven't had maintenance care. There are substance use concerns. There's trauma-related mechanical issues sometimes. or mostly there are these rare conditions like the PFO that I discussed earlier, or there's family history of early cholesterol deposition where that lipoprotein A molecule becomes relevant. There are some hereditary genetic autoimmune clotting conditions. Unfortunately, it's rising globally, but so that's why it's more important to be vigilant even at a young age. So we took care of a 35-year-old a year or two ago who presented with to Providence St. Vincent with sudden onset of one-sided symptoms, left-sided weakness, clumsiness, arm and leg weren't coordinated enough, trouble walking, and the only other symptoms she had some neck pain a week before coming to us with above symptoms. Her initial CAT scan looked okay, no concern, no bleeding, no evidence of fresh stroke yet. When we did the MRI, we found out there's some small areas of clot, and because she presented within 3 hours, 4.5 hours of having all these symptoms, she was treated with clot busting medication. So then doing this exercise of what do your vessels look like, we found out that this is a video, and this is the front view of the vessels in the neck. So this is the right vertebral artery, which doesn't supply the area involved. We're just looking at it how it should be looking, nice and smooth through and through. This vertebral artery sits next to your spine. So comparing right to left, right here, there's a thinning of this vessel and this irregularity of the vessel compared to the other one. And this is like a kind of a comparison between how the right and left looks and how there is irregular. This is a condition we call a dissection, where there's a flap in the inner wall between outer walls separates, and this flap opens and there's blood that gets in between, and you can either have interruption of blood flow in the homemade proper channel, or it just forms clot on top of this and breaks loose and fires down and causes more strokes. In her case, she actually had a tendency from childhood to crack her neck habitually, and we think that's probably caused it. Oftentimes, young patients, we think about any history of neck massage, neck manipulation, contact sports, roller coaster rides. Fortunately, she did okay. She has had no long-term symptoms because of the small strokes. We counseled her on avoiding the neck cracking, which is easier said than done. But at most 85% of these resolve on its own. This is a follow-up scan, and this vessel looks like nice and open compared to how thin and irregular it was in the beginning. So just an example of how certain non-risk factors, this is not something you could have controlled in terms of tear, or it's a mechanical trauma, different issue than some of these other modifiable risk factor stories that we spoke about earlier. So in summary, we spoke about sort of pain and health and disease. I'd learned about the stroke symptoms, identifying the risk factors, looking for the cause of the stroke, just doing this whole exercise. How is your vessel looking, or how the whole tree looking like, looking at the heart, and understanding, and based on that, coming up with an appropriate plan for prevention of a stroke. So with that, I'm going to turn over to Dr. Dussell. He's going to talk about the large vessel stuff.
It's fascinating. I say this at the beginning of every carotid speech I have. Yeah. The reason it's named the carotid is because in ancient Greece, where the name carotid comes from, it actually means to mumble, because back then they didn't have aspirin or statins. They did have a very good Mediterranean diet. However, if you were wealthy and you didn't follow that Mediterranean diet, you would develop a large lump in the side of your neck associated with all of a sudden garbled speech, which is one of the highlights of stroke. And so they named the blood vessel after the disease it produces. So carotid means to mumble in Greek. It's aphasia associated with carotid disease. And since it was so bad, you could actually feel the carotid plaque underneath it. We have a very good way of treating this, not since ancient Greece, but since the late 80s, early 90s, we've been doing carotid endarterectomies. Before heparin, we were doing carotid endarterectomies because it is easily the most studied and tested procedure, I would say, in medicine. It's there we go. All right. So first off, we have a vascular clinic. We do not screen necessarily for carotid disease because you're going to find something. The question is whether or not there's anything to do about it. And so the USPSTF, the Preventative Services Task Force, looked and said, should we be doing ultrasounds on just everyone, or should there be some sort of indication? Because most of the time, after I've done some sort of carotid work, the patient will come back and say, what about my other side? Is my other side going to be a problem too? Because if it happens somewhere, it happens everywhere. I mean, that's the point of blood vessels. If you have vascular disease, it's happening all over your body. This is just the thing that's waving the red flag. And so in the general population, we're not running around with our ultrasound trying to find our next lunch. It's the reason that we look for it used to be a Brewy, but a Brewy is a 50% guess. It's a coin flip as to whether or not it's actually indicated. And so they had to parse it down to the people who are basically high-risk patients for not only blood vessel disease, but high risk for blood vessel disease that is going to cause them a problem. I have the same conversation with patients about statins as you do. We see all this stuff in the news. It causes dementia, and we're using it to treat dementia. I don't want to be on another medication. Your house is on fire. Put out the fire. A statin medication in our patient population, vascular patients, should be in the water, mainly because it does everything that was previously described. It not only works to decrease your blood cholesterol, because that's mostly what people associate it with. It stabilizes plaque. Plaque stabilization is the name of the game because, and I say this probably 3 times every clinic day, if you don't smoke, if you get moderate exercise, and you take your aspirin and statin and maintain a healthy diet, you'll never need surgery from me, ever. And that's in patients who come in with any brand of blood vessel disease. I've had patients who have been between 70 and 80% stenosis, asymptomatic, from my initiation to Oregon 10 years ago. And the medications that we have are so profoundly good that they're changing the parameters by which we actually offer operation, which hurts me. But nevertheless, I only like to operate on people who I'm actually going to help. And so there are basic parameters by which we evaluate people. And the patients who are in my clinic are going to be high risk. They're going to have diabetes, hypertension, coronary artery disease, because again, blood vessel disease anywhere. And then high risk, so lifestyle factors. As he said, we have very cool tools. It's one of the perks of being a vascular surgeon. You get to do all kinds of absolutely science fiction things. Everywhere in the body, we have seen a revolution from endovascular therapy. And as he said, we use it, they apparently use it in the brain, which is wild to me. That's extremely cool. Those vessels are so small, but I think it's probably because you have a low resistance bed that it actually works well. A lot of the problems we have in the periphery is that the blood going into muscle, so your legs or your heart, they get a lot of back pressure because you're trying to push into very solid organs, which are the muscles. The brain has a low flow state, so it gets constant flow. It's constantly getting oxygen because it's a selfish bugger. But I think that's probably why stents work extremely well there. However, carotid disease is still done 75% open or open surgical. Now that's good because that's what's going to make sure that I have people who are going to be doing vascular surgery long into the future, because it's the prettiest surgery that we do. It's the best. It's the best surgery, except when your name's on the chart. When you're training, it's very cool. You get this like beautiful anatomy lesson. It's incredible. But from the opposite side of the table, when you're attending, the moment you clamp blood flow to the brain, my heart rate goes 3 times high. She's been there. She's seen it. She knows. And so the question is there a role for endovascular therapy in carotid disease? We have a good procedure. carotid endarterectomy. Why would we change it over to a stent? Well, we tried to do stents from the groin. Just as in all the pictures that you just saw, you can get plaque from anywhere and it will go downstream. Downstream from everywhere from the groin to the aortic arch goes down towards the feet. Not great, but nevertheless, it's something that we can manage. Once you reach the arch and you start tinkling around in there, fragile plaque that we know is fragile because the person just had a stroke is going to get manipulated. And so it's something that caused major concern. So for the last 15 years, we've been toying with this idea, but only in patients who it's really a salvage maneuver. You don't want to do a femoral stent, mainly because the amount of strokes associated with that procedure is prohibitively high. If you're having in a symptomatic population a stroke rate perioperatively of 6%, you shouldn't be doing surgery. And that's 3% in asymptomatic populations. This is 15%. It's so high, it has become a procedure that we only offer when there's absolutely no other choice. So how do we, so rationalizing it to either the sickest of the sick who needs something done and we want to help somehow, that's your femorals. But carotid is working fine. Why do we not just do this? Well, the procedure length. If I can get 2 procedures done in the same amount of time I can do 1, inherently it's a better choice. If I can ensure that the length of stay is shorter, that the patient has less pain, that the complication rate is lower, significantly lower, it seems like the gold standard needs to change. And so we tested the idea of stents. We know that stents work, but we don't have a good delivery system yet. The way that we know that is because for the last 15 years, we've been doing femoral stents. We know that in that location, stents work. And for me, the major concern was that we'd put in a stent and it'd be like the femoral system, where every year, every 2 years, we'd be right back doing balloons or angioplasties, putting in new stents. Stents would go down and it would be a big problem. I've been doing this for about a decade and I haven't had one of these have a problem yet. And I think that's because the blood vessel going to the brain is very different than the blood vessel going to the heart, going to the leg, going to the arm. They have different physiology. And in so doing, as soon as that stent is in, you have a long-term durable answer. And this is going on about 15 years as far as stent patency, thanks to the people who trialed the transfemoral stents. Although I know what you're thinking, like if they were putting a transfemoral stent in and we're still checking it at 15 years, did they really need the transfemoral stent? No, probably not. But nevertheless, we had good data because of it. And like we said, the aortic arch is such a source of stroke that even with a very careful application, you still need to pass through the lesion in order to put some sort of embolic protection distal. So no matter how good you are, you're still manipulating inside the lesion to put your endocatch basket in so that you can do your stent. And you'll find that there is always microemboli. Independent of when that happens, the aortic arch becomes the source. And so we created a paradigm shift. You still have a minimally invasive procedure with a less than 2 centimeter incision. You avoid the arch completely. The cranial nerves, which we live in fear of when we're doing our dissection, the hypoglossal, the vagus, these are bigger when they're closer to the heart, and they also are farther away from the vessels that we'll be manipulating. And so therefore the cranial nerve injury, a complication associated with carotid disease, has dropped off the map. And then you also have I don't know that it's proprietary, but it's the flow reversal system associated with TCAR, transcarotid artery revascularization. So instead of going femoral, you go transcarotid. So what we do is we do a cut down just above the clavicle and find the common carotid artery. Then we stop flow going from the heart and use the circle of Willis, the other 3 blood vessels, bringing blood to the brain, to essentially reverse the flow of the blood down into our catheter system. not only does this ensure that no distal emboli goes towards the brain, but we actually take anything that could be embolic and bring it back into our sheath. We don't just let it dip out to the floor, though. We return the blood to the patient through a filter, through their femoral system. And that's the benefit of having that neuroprotection. This is a particularly bad case, but that's a real case. That's a case that I had. And what you got to consider is that in a patient who has had a symptomatic stroke from a carotid source, the benefits of aspirin, Plavix, and statin have had maybe as small as 2 days and as long as 13 days to do their work. So these plaques, while they're getting optimal medical therapy, at this point, have not had nearly enough time to stabilize the plaques that you're having. So the plaques are high risk. We know that. They're bad actors. They've done a problem already. And so therefore, having this takes my blood pressure down to a normal level. And also it changes the pace at which we can do this procedure. Like clamp time, even to get a shunt in so that I can bring blood from a clamped proximal to a clamped distal area while I'm doing my open surgery, is still less time than it takes for me to put in a stent. I don't have enough time to get anxious. That's not true, but nevertheless, to play. So historically, because femoral stents came with such high morbidities and mortalities, we had to keep them at high risk status. And so all of these are high risk patient qualifiers. But the problem is that we were getting such good data from TCAR, and the stroke rate was lower than open carotid surgery, and the MI risk was half open surgery, that we wanted to expand the population to a less than high risk population. There was studies done based on the early impact and adoption of TCAR, and it's just like a nomenclature thing that I really love. The learning curve is short and steep. Steep learning curve doesn't mean that it's bad. It actually means that it's incredibly easy. And what we found is that incorporating this into practices, whether they had it before, whether they had a dedicated carotid program before, or whether this was the start of it, it brought outcomes remarkably better. As you can see, the use case here is going significantly up, and our open carotid surgery is actually going considerably down because of all of the reasons that we've established, that it is safer, easier, more accessible, and it incorporates more into its production. And so our current vascular guidelines are in any patient with greater than 50% stenosis who is symptomatic or asymptomatic at 70%. Our practice, Oregon vascular practice, is actually 80%, because these guidelines are based off of essentially archaic studies before they even had really appropriate statin use, before they had legitimate aspirin use. So if you want to get aggressive, if you want to be an aggressive vascular surgeon, you can operate on asymptomatics greater than 70%. But in practice, you'll find that these are the patients who don't need it because their lesions are not particularly active. And this is borne out throughout the data as of 2 years ago. But the asymptomatic is still considered at 70% stenosis. So when do we use TCAR? That is a very surgeon-dependent thing. Now it has been opened to the general population. You can theoretically use it for every case that you want to. I personally veer more towards TCAR than I do towards open carotid surgery. My partner, Dr. Cook, veers a little bit more towards the open carotid surgery. Dr. Santo is a 50-50 guy, and Brandt is whatever's fastest. And we all have moderate outcomes, similar outcomes. The issue is that all necks are not the same. The guy to the right, I don't know where you'd begin to make your incision. On the second one over has had radiation therapy and therefore is high risk for wound breakdown if you were going to do a native carotid. Transfemoral stenting on the guy in the middle would be almost impossible because of the amount that you'd have to lift of that pannus. And then patients with tracheostomies are also extremely challenging to do an open carotid surgery for risk of infection. The thing on the right is for cervical disease. We have some patients who have essentially fused necks, and therefore trying to manipulate them forward and away is almost impossible. You can move the entire patient based off of their neck, and therefore you would not be able to get the appropriate extension in order to do an open surgery in these patients. But there's also challenges to endovascular anatomy as well. All that white stuff on the bottom right there is all calcium. Can you imagine trying to take it? The car analogy is perfect. Imagine trying to drive down a highway that looks like that, and all of that is snow. You think you're going to make it? Your car is going to get through all that without getting absolutely dumped on? It's not possible. And then the angulation of the aorta. There are certain ones that are very, very easy to endovascularly access. Those are the type 1s. Those don't exist because I made bad choices. Type 3 is generally the older population, and type 2 is what we generally see. But they can make manipulation very, very challenging. Oh dear, Shannon's saying that they can't see the slides. Is there a way to change that? Trying to do a femoral approach to the carotid system from a patient with Lariche syndrome, where you have a complete aortic and iliac occlusion, would be pretty challenging. It'd be damn near impossible. And so when you start to evaluate plaque morphology, you can see heavy carotid calcification, that's that white stuff, and then fresh clot here. So you're supposed to have this nice white stuff. That's going to be the blood. As it passes up, you get your external, comes out like this, and your internal that comes up like that. You've got circumferential calcification here and fresh clot, which means that if I was to go in there and try and poke that with a wire, all that fresh stuff is going straight that way. And I probably wouldn't be able to get past this. Whereas when you have a clean line and an obvious source and no findings distal, these are going to be patients who are going to perform very well with a with a TCAR. Oh, thank you. All right, so like I said, in patients who have circumferential calcification, where the lumen is extremely small. Hey, all right, cool. Thanks for chirping up, Shannon. There's actually a new study that's happening in patients with this sort of lesion. So it's going to be in high-risk patients. You're going to have circumferential thick calcification. And what they're going to do is use shockwave or ultrasound therapy to crack the plaque in its medial incision. So when you're looking at this is a very dense plaque, super, super dense plaque. But if the patient's high risk and cannot get open surgery because of one of those reasons, the neck radiation or infection risk, or so if there is an indication, then we have to think of an endovascular therapy for it. So how do you break this all up? Well, you've got a flow lumen, and you can't see it on this, but there's no other signs of fresh, soft plaque. And so if you were to create micro tears in the calcium, not the intima, not the innermost portion of the blood vessel, but the calcium in the medial wall, you can crack all that plaque so that it becomes, from instead of a wall of calcium where it's just a pipe, it becomes like a bag of sand that then you stent open and it keeps it out. Whereas this sort of eggshell calcification is just perfect for stenting, because you would open it up and these things would move completely out of the way. Yep, greater than 3 millimeters. Now, there's always going to be a rule for carotid endarterectomy, namely in your patients who have, we do not like operating on dissection, and if we get away with it, we do. But in some of these patients who have dissection, I haven't had one yet. Yeah. I don't look forward to the first one because they're really, really tough to treat. But when you have dissection, you have what we call free floating thrombus, clot, that's your body tries to do its best all the time. And what it wants to do is stop the blood from going in this really turbulent, flowy way. And so what it's doing is it's putting as much clot down as it possibly can, but what your heart is doing is shooting as much of it towards your brain as possible. If you were to try and stent this, it would likely have the same effect. You get through it, but all of that fresh clot is going somewhere. Now, theoretically, you could put in a stent and hopefully it would come back down. But these patients, you favor a carotid endarterectomy because really what you can do is clamp distally, clamp proximally, and then when you open it up, it's like Mickey in Fantasia, but instead of water, it's clot. Unstable plaque is really scary stuff. And so there are specific clear advantages for each of these procedures. And that's why it's not a monolith. We can use both. Specifically, the carotid is very, very useful when there's tortuosity at the site. Tortuosity and stents don't get along. A stent is, as he said, a cage. It's just a metal cage. It's a scaffolding that helps push things out. And so therefore, if you have a tortuous blood vessel and you put in a stent, all that tortuosity gets pushed up or down. And the worst case scenario is you put in the stent and what it does is it cuts it off. And so now you have a right angle. Your body really doesn't like those and it'll just shut off flow completely. And so what we end up doing is we take the carotid artery itself, cut it, and place it down and make it straight. There are certain other morphologies that we use to evaluate it, but things like high bifurcation, hostile neck, reoperative site, or significant cardiac disease. So none of these patients have carotid disease in their alone, and having a clamp on the carotid artery for an hour versus having a clamp on the carotid artery for three minutes, which is the difference between an open surgery and a minimally invasive TCAR, decreases the cardiac load significantly, mainly because when we do that clamp, we ask the anesthesiologist to put the blood pressure over 140. Now, when you're under anesthesia, you have someone else doing the physiologic function for you. It's not asleep. You're not asleep. Think about it as if you're undergoing anesthesia, you're going for a run. And if you've seen any of our patients in pre-op, you'll know very few of them go on runs regularly. And so while they're under anesthesia, the least amount of time that they can be getting general anesthesia, the better off they're going to be. That's a clear advantage to TCAR for me. So long-term surveillance after our surgeries, if it's less than 50%, we return them to their primaries. If it's 50 to 69, we have them follow up with an annual evaluation. And then over 70, we do allow patients to take part in the conversation between 70 and 80%. Almost universally, they do not want surgery that they don't have to have. The risk of having a stroke is so low from a medically optimized patient that the risk of going to the operating room is unnecessary, up to 80%. And then post-operatively, it's a lifelong annual duplex to make sure that either our carotid endarterectomy or our stent is patent. We are here, and the comprehensive carotid program that we have has continued to improve outcomes. So we're really grateful to be a part of it. Yeah. What questions you guys have? And out at home.
I'm not in the medical field at all. I just thought this was going to teach me what to do and what not to do, what to eat and what to do.
Sure.
But when you talked about the ones that come from the leg and come up, are there any ways of detecting that ahead of time, or only when it finally happens, or any prevention, or are you just talking about cholesterol? And when you talk about clots, you're talking about cholesterol, not blood clots, right? You're talking about cholesterol, is that correct?
No, so
It's
specifically for carotid disease, cholesterol forms the high risk area, and when it is in interaction with the bloodstream, it clots off. The clot tries to protect the rest of the blood from the cholesterol. And so we do have, theoretically, we do have cholesterol plaques, but what those plaques are is cholesterol that has been glommed on by platelets, by the blood. So it's always going to be a blood clot.
They're piggybacking on it. or
Correct.
something.
Yeah. They're surrounding. It's kind of like an M&M, but
Oh,
the
okay.
worst kind you can think
Or a
of.
snowball.
Right.
Yeah,
Well, kind of. Yeah. The snow would be the platelets and the clotting factors. The innermost nugget of that would be the cholesterol.
But you have no forewarning. Say you did have something, the deep vein thrombosis, whatever. If you do you have any
It's
warnings of that?
extremely-
You don't get screened for it.
No, that's true. In order for that to happen, though, so many different things have to go wrong. It would be like trying to get a pencil through Swiss cheese. You have to, number one, have a blood clot in your legs. That's not that. As far as the general population go, it's not entirely common. So you would have signs of a blood clot in your leg because it has to be a relatively large thing. And then also you have to have a hole in your heart, which again, rare. And then the blood clot has to go up into your heart through that hole and then be sent to one of the blood vessels in your body. Sometimes it is your brain, but it is so extremely rare that the need to test for it would be too big, and you'd end up treating too much to be safe.
Symptoms of a blood clot in your leg, like when you'd be worried that you had one, people get swelling and pain, usually in their calf.
More like pain. I mean, I wear compression stockings, but that's just for
so the compression stockings, you're often treating like varicose veins
Yeah.
and kind of discomfort. But if you get like what feels like kind of like a knot in your leg and it's painful, that's typically the symptom that people.
And that's the
report.
first warning sign you get.
That's usually it. Yeah.
And then you go
And
to
you
your
go
next step.
and get an ultrasound in the ER usually, and they check it and see
Okay.
where you're at.
That whole process is so rare, but oftentimes we see this in people who've had like a knee surgery or something. They've been immobile for 6 weeks. Like it's very unusual to form a clot in the leg. But I showed that whole deal as an exercise to say we gotta look at the whole thing.
And that's why they have the
Like,
heparin
look
or
backwards.
whatever to.
Correct. Like when someone
Okay.
has had a stroke. You see people who've had an intercontinental flight. You're sitting in one place for 10 hours, not drinking water.
Okay.
Very, very rare. But others are much more common. 1 in 4 people actually have that valve in the heart, but we don't see as many people having strokes. So oftentimes that's actually the least likely way of having a stroke.
So you're talking more about the heart than you are even the brain, because I guess because the heart is the blood passage and
Correct.
everything.
Correct.
Okay. So when that person had no other symptoms but had vertigo and dizziness and vomiting and all of that, how does that relate to, like, sometimes I have cervical vertigo because of somehow how I slept and stuff like that, but I have none of the others.
Right.
I live a
Right.
normal life. So
Right.
I get scared sometimes, nip things in the bud.
Yeah, in the emergency room, and it's challenging for us as well, because sometimes people have this vertigo from inner ear issues, and it's how do you differentiate? There are some signs that you look for, and what are the
But
eyes?
not related to this. I would have more symptoms or a numbness or something or
correct,
whatever.
That
Okay.
person just would not be able to stand.
I worry because
Yeah.
I lost my 24-year-old son 10 years ago. They took his right brain at 3 times. The tumor was bigger than a baked potato, was 3 inches by 3 inches by 3 inches. And they kept treating him for headaches until I demanded an MRI. And they immediately flew him by helicopter for a 9-hour craniotomy and did that 3 times after that. But so I believe in nipping things in the bud.
Right.
Yeah. Thank you.
We have one line for stroke prevention. When would either of you recommend someone to take a baby aspirin daily?
Put it in the water. I'm kidding. That's a conversation between you and your primary doctor. The issue is that it is a heuristic medication. It is a platelet inhibitor, but it also decreases the irritability of the blood vessels themselves. And so if you have cardiovascular risk factors, family history, or you've had some sort of high risk labs, that's when they would start putting you on it. I have a family history of coronary disease. I've been taking it since I was 35. That being said, the USPSTF does not recommend that everyone take aspirin, mainly because there is associated risk of brain bleed associated with it. And so that is a conversation between a patient and their primary care. But anybody who's coming to my clinic is going to be instructed to take it.
Yeah, I would say exactly the same thing. It's a risk versus benefit. We don't recommend it for everyone if you've been completely healthy, you've never had have no risk factors. Then the benefit might be lower than the risk, especially at age 30. But as time goes on, 50 onwards, if someone's a smoker, someone has had a high cholesterol, have had heart disease, then the answer is definitely yes. And then most people fall in between. So it's 10 years ago, it was recommended to everybody. Now, as we have more data, things are changing for primary prevention, meaning you haven't had any disease, but you're trying to prevent a stroke or heart disease. So again, it's individualized, and that's the best way, in my opinion, rather than one blanket approach, yes or no. Like, hey, let's just look at everything and then kind of come up with a risk factor profile if you're in moderate to high risk, and then you don't have any bleeding concerns like an ulcer or bleeding anywhere else. Maybe a better idea to take it than not take it.
Nothing else online.
I have a question for you.
Yeah.
So in your patient population, when you have a patient who has AFib and they've had multiple falls, regularly their primary doctor will take them off of their anticoagulation. This is something that I run into regularly too. And it's appropriate. However, what I have found is the education as to the risk of being off of that anticoagulation. Is that also a problem for you?
100%.
It is incredible. It is challenging as anything.
Especially if they've had an embolic stroke. Like
Right.
Embolic
Exactly.
But that's why we've been using Watchman procedure a lot.
Watchman, okay.
And especially for stroke patients, like if you've already had this issue, you can't have this. Sometimes even if they're elderly and 80, 90 and above, even if they're not falling, sometimes it's good to have that proactive conversation. Hey, you're not falling now, but maybe 3-4 years down the line, probably this might be an issue. So just think proactively about it. And we're going to have a situation maybe 3-4 years where the data is going to be as compelling as a DOAC.
Right.
But we're not there yet.
Yeah.
The gist of that for non-medical people is that you have people who have atrial fibrillation where part of your heart doesn't squeeze blood out very well, and the way that we usually treat it is we put you on a strong blood thinner to prevent clots. And then if you start having falls, you're at a risk of banging your head and bleeding into your brain from the fall. So we'll take people off of the anticoagulant in order to prevent them from possibly having a brain bleed. And then they might have a stroke after that because there's nothing now that's protecting them from the atrial fibrillation. And the Watchman device is like a little...
Like a barrier, like a little membrane, like a curtain we put it in people. There's it's a balloon in a balloon for the top left chamber of the heart, and 90% of the clots form there. So like in a smaller balloon and a big balloon, so you want to just kind of close that off. It serves no purpose in life. It's just like that's why it's called an appendage. And then you close that, so then you kind of take care of the place where clots are formed if someone has atrial fibrillation.
So if I'm running low cholesterol in all my physicals and I've got a low BP and no triglycerides, so far so good.
Yeah.
Okay.
It means you're doing some things right already. And you're genetically blessed. A lot of people have high cholesterol endogenously, like genetically, like from not their diet, but
Okay.
Unfortunately, it's not the sexy stuff that actually does move the needle. Exercise, no smoking, taking the medicines you're supposed to take. That's like 90%
I'm
of
on
it.
no prescriptions, and I'm trying the Mediterranean. My son lost 115 pounds easily on the ketogenic diet. He lived 30 months longer than they said he would, and he was never as healthy in his whole life except for the ticking time bomb in his head. So I know the ketogenic diet works.
So if you, maybe you already said this, if you have some crusty or some plaque on your vessels, but you don't really know it, you haven't had a stroke yet, but if you do your diet and your exercise, does that kind of go away like weight loss, or do you just stop
You stop the progression. Yeah. So
you can't reverse it necessarily?
no, think of it like a scar on your skin. If you get a cut on your skin, it bleeds. And then if you take, if you take it and you put it under the water and you brush off a clot, it bleeds again.
Oh, you can't
However,
really
after protecting it for a certain amount of time, it scars in. and you can put a fire hose to the thing, it's not going anywhere. So that's the way to think about a plaque. Plaque and plaque rupture, they're basically like a wound. And externally, it's just that the skin is a little bit more pliable than the calcium we put into the neck. I had an attending who used to say that there is a way to take calcium out of the blood vessels. However, it's not a lifestyle anyone wants to live. It is so restrictive as far as diet goes that it would be incompatible with life. It's extremely, extremely challenging. And so the idea is, just like the fire analogy, the best thing that you can do is stop the flame, and then you can start working on the rest of it. So everyone has blood vessel disease. Babies come out with fatty little pads. So everyone's got it. The question is how many miles on the tires you got. So how long that plaque has been working on you, and then what you've been doing in the interim. And so, staying away from smoking, vaping, holy crap. Smoking or nicotine in general, it's phenomenal. They'll come into the clinic and be like, okay, well, I'm not smoking anymore, I'm just using dip. Okay, but nicotine still is a vasoconstrictor. And what the vasoconstriction does is it mimics hypertension. And so it's basically the same thing. It's not as bad because you're not getting the hypoxia, you're not getting the tar, but like you're just trading one hypertension for the other hypertension. And so nevertheless, no, calcium in the blood vessel doesn't go anywhere. If you take your medicine and you stay away from toxic habits, it can solidify to the place where it will be a problem. Yeah.
That's not as good as what I thought it would be. It would just seem like all you're doing is preventing it from getting worse, but you can't go and reverse. You can't reverse engineer what's already happened.
Nobody can turn the clock back. It's part of aging.
Nothing will scrape it off.
Zero. There's zero ability to scrape it out except for me and probably a spoon. Yeah.
But it's all through. It's
everywhere in your body. So they didn't consult us when they were creating the humans. And so what happens is that as he said in his picture, the favorite picture, oh my God, the flow diagram. The issue is that you get eddy currents. So your blood is going, it's like driving on the bridge. It's so fast. It's going so fast that when it turns into these branches, you get eddy currents. And you'd think, okay, you got slowing of blood flow around these bifurcations, these areas of why. The slowing probably is nicer, but what happens is you end up getting turbulent flow and deposition. And just like, on the Willamette, the deposition will build up. And that's something that every time your heart beats is happening. This is, I love this diagram. So you got laminar flow. Your body wants to have laminar flow. It wants to go in the right way. It wants to do the right things. But as you can see, once that flow is disturbed, you get eddy currents. And these are the places that we get the carotid plaque. And they're the most easily seen, but you have these bifurcations everywhere. And I think that's probably why those small vessels, those scare the crap out of me, man. Yeah. But I love that picture. That is so great.
I liked all the AI pictures.
They were really interesting. The sphygmomanometer that doesn't attach.
I noticed that.
Oh yeah, the nuance to it is amazing. If you like, they look great on their face, but it looks like he's about to inject himself.
Yeah. That's fantastic. Thanks for picking that out.
Oh, absolutely. In the bad foods, I was like, the chili's great for your heart. Garlic, phenomenal. Ginger, the olive oil, the pepper. Yeah. I love the LDL fries though.
Yeah.
Oh, is that what it says on it?
I was imagining a houseboat.
That person looks like he's in the Matrix.
Mm-hmm. Yeah.
Those are great.
That's the moment when he's doing surgery.
That's it. Yeah, that's what I look like.
Do your matrix.
Exactly.